Now, welcome back to the second part of sympathomimetics, in which we will have some concepts of sympathomimetics. Now, we have been discussing catecholamine and non-catecholamine. First of all, let's have some tabulated differences between the catecholamines and the non-catecholamine. So, in catecholamine, we know they contain catechol ring, which means hydroxyl at the position of 3 and 4. So, obviously, they have strong pharmacodynamic activity, alpha and beta activity. While the non-catecholamines, they either have absence of one or both the OH ion at the benzene ring. So they have weak activity, alpha and beta. But something we have seen, if isopropyl is added to that, they may enhance the beta activity of the non-catecholamine. In case of catecholamine, there is no substitution seen at the level of alpha carbon. So their duration of action is always very short. So all catecholamines have short duration of action. Epinephrine, norepinephrine, dopamine, isoproterenol, etc. While in case of non-catecholamines, because there is always some substitution at the level of alpha, so they have comparatively prolonged duration of action. Another important observation is that all catecholamines are inactivated by the COMT, catechol O-methyl transferase, that we have already studied in biochemistry. So that inactivation occurs both in the GIT and liver. So it cannot be given orally. So they are given always parentally through injection. While the non-catecholamines, because they are inactivated by the monoamine oxidase enzyme, especially if no alpha substitution is there, so they can be given orally. So we have seen oral bioavailability in case of non-catecholamines. Another thing is, because usually they are always carrying some charge on their molecule, so they are unable to cross the blood-brain barrier. So they do not have any effects on the brain, no central effects. While the non-catecholamines, because there is absence of hydroxyl ion, so usually they are uncharged, unionized, so they can cross the blood-brain barrier and they will show the effects, especially the central effects on the brain. Another thing is they are highly potent. Highly potent means even the smallest dose of these drugs can produce the maximum possible effects. So that is why if we see the ampule or injection of epinephrine, we give usually in very diluted form, usually 1,000 times diluted. So even that diluted, highly diluted, 1,000 times diluted of epinephrine, only few drops of epinephrine can produce highly increased effects on the body, increased sympathetic stimulation we observe. So they are highly potent. While these non-catecholamines, they are not as much potent as the catecholamines. So they have low potency. So their dose is usually in milligram. Their dose is in microgram. Examples are, obviously we have already seen catecholamines, norepinephrine, epinephrine, dopamine, isoproterenol, and non-catecholamines, phenylephrine, ephedrine, and amphetamines. So epinephrine on one side is having catechol rings because one of the catecholamines, so having strong pharmacodynamic activity. But regarding substitution, due to substitution of the OH ion at the level of beta site, will increase the alpha affinity. So having strong alpha affinity for the alpha receptor. While substitution of the methyl group at the alpha side, they can have increased a strong beta affinity for the receptor. So epinephrine in principle is very strong alpha and beta activity drug. As compared to norepinephrine, because there is no substitution at the level of alpha side, so no beta activity, but they raise OH presence at the level of beta side, so having strong alpha beta. So difference between epinephrine and norepinephrine is epinephrine is having both alpha and beta activity, while norepinephrine is having mainly or only alpha activity. So that is the basic difference for you to remember. Now let's have a again discussion on the adrenergic receptors, different types of receptors. We already know okay, adrenergic receptors are of two types, alpha and beta. One types are all stimulatory, two types all inhibitory. Now, alpha 1 receptor. Now, this is the one of the most important types of receptor which are present on different sides of the body, including the arterioles. The first thing which should we come in our mind regarding alpha 1 receptors is the arterioles, because here actually there is intense vasoconstriction of variety of sites of arterioles present at the level, especially skin and mucosa, abdominal viscera, and renal vessels. At the same time, there are some sites where moderate type of vasoconstriction is also present, like at the level of skeletal muscle. And even mild type of vasoconstriction have been observed at the level of coronary vessels and the pulmonary sites. Now, if we give the agonist systemically, or if we observe systemic stimulation of the sympathetic nervous system, there may be vasoconstriction at all these sites. So that will lead to increase the peripheral resistance. And we know when there is increased peripheral resistance, there is raised diastolic blood pressure. And this condition is usually used, as we know, in case of shock. Now, if the agonists are applied locally, for example, in the eye, in the nasal mucous membrane, etc., so obviously then the vasoconstriction will be produced locally only, and that will lead to decreased local blood supply at that particular site. And this effect is usually observed, for example, to relieve the local congestion. For example, severe local congestion leads to blockade of our nose. So we can use alpha 1 agonist to get rid of that. Even vasoconstriction produced by any other means, by strong pressure at the local site or by some applying severe cold like ice on the local site, that will produce vasoconstriction. So idea is the same. And at the same time, that can arrest the local blood supply also, so local bleeding. Now the next important side is the systemic veins. Here again, alpha 1 present, so stimulating nature will produce constriction of the systemic vein. And obviously from our knowledge physiology, we know that will lead to increased venous return. And obviously that will help to increase the stroke volume and ultimately increased in cardiac output. But at the same time, that can add on the workload of the also of the heart. Other sites are neck of the bladder. Here again specific type of alpha 1A receptors are present, the contraction of which can lead to retention of urine. But here remember, this activity is used by blocking these sites. For example, retention of urine if occur, especially in cases of in old male patient when there is enlarged prostate gland. So retention of urine is a very common problem with those. So usually then we give blocker of these alpha 1 type A receptors. And obviously instead of contraction, then there will be relaxation of the smooth muscle of neck of the bladder. So retention of urine is relieved. So this effect is used especially by the blockade. Radial muscle of iris, that are also constricted, and that will pull the pupil outside, leading to producing the mydriasis. But this effect is only at the level of radial muscle of iris, no effect at the level of ciliary muscles. So there will be no sarcoplegia, no loss of accommodation. This is the basic difference between the mydriasis produced by anticholinergics and the sympathomimetic acting at the level of alpha 1 receptor. Then the Fifth site, important site where alpha 1 present are aqueous humor. So stimulatory nature that will lead to increased outflow of the aqueous humor from that site, and that will ultimately reduce the total quantity of the aqueous humor and decrease intraocular pressure. This effect is also used for glaucoma. Now alpha 2 again inhibitory nature. So because specifically they are present, and more important site is the presynaptic sites of medulla especially, and even at the peripheral nerve terminals. So being inhibitory in nature at both sides, it will lead to produce decreased sympathetic activity from medulla, decreased sympathetic outflow for all the sides of the body, while at the level of peripheral nerves, at that particular site, there will be decreased sympathetic activity. Now this decreased sympathetic activity, central or peripheral, is helpful or useful in case of hypertension to reduce the blood pressure. Other sites are postsynaptic sites, and the important one is the ciliary epithelium. So inhibitory nature, they will decrease aqueous humor synthesis and total quantity is decrease, and decrease internal pressure, again useful in case of glaucoma. Also present at the beta cells of Langerhans, so decrease insulin production, so obviously there will be hyperglycemia. So that will lead to persistent hyperglycemia if there is persistent sympathetic stimulation due to activity at the level of alpha 2. Another important site at the lipocytes will lead to inhibition of the lipolysis. Now the next, one of the most important site is the beta 1 receptors present in the heart, and in the heart present at all the level of smooth muscle of heart and the connective tissue of ventricle, atria, AC node, AV node, bundle office, etc. And being stimulative in nature, it will increase the activity of all these sites. So by increasing the increased activity at the level of smooth muscle, it will increase the force of contraction, positive inotropic. And from SA node, positive chronotropic, increase heart rate. And at the level of conductive tissue, increase thrombotropic effect. We've already seen in the previous discussion. So usually these activity, increased force of contraction, is utilized especially in case of acute cardiac failure. But we have already seen, due to increased activity of all these levels, increased cardiac output and improved venous return leading to increased cardiac output again, increased heart rate, all are leading to increase in workload and increase in oxygen requirement at the same time. And from thrombotropic effect, even we can see various types of development of arrhythmias. Another important site of beta 1 receptor is at the level of renin release and ADH secretion. So there will be increase in release and increase in secretion, which ultimately, from our knowledge of physiology, we know there will increase blood pressure. As far as the presynaptic site of beta receptor, they also have beta 1 receptor, so increase beta 1 activity at the level of presynaptic site, especially at the peripheral vessel. So there will be increased release of norepinephrine at these vessels and may lead to vasoconstriction. GIT, again beta 1 receptor. Due to increased activity, we have seen there is a sort of hyperpolarization present, which is obviously hyperpolarization will be a sort of inhibitory effect. So there will be relaxation of GIT smooth muscle due to increased sympathetic stimulation, but that is due to hyperpolarization. Beta 2, inhibitory nature. So wherever they are present, so obviously they will produce the relaxation of those sites, especially at the level of bronchial and tracheal smooth muscle. So there will be relaxation of these muscles, and these activities helpful in relieving the bronchospasm as seen in case of bronchial asthma or COPD, chronic obstructive pulmonary disease. They are also present at the level of uterine smooth muscle. So if there is strong uterine smooth muscle contraction, as we see in case of threatened abortion, so that may be helpful to relieve that strong contraction of uterine smooth muscle by giving these beta 2 agonists. But clinically, we have seen they have little clinical importance as far as the uterine smooth muscle is concerned. They are also present at the level of blood vessel, especially supplying to these sides, liver, skeletal muscle, cilia epithelium. So there will be vasodilation of these vessels. So there will be increased local blood supply to the liver, to the skeletal muscle, to the cilia epithelium. So there will be increased activity of all these sites, increased metabolic activity, increased motor activity, and increased cilia epithelium activity. But at the same time, due to vasodilation of all these sites, there will be decreased peripheral resistance and decreased diastolic blood pressure. So on alpha 1 activity, there was increased peripheral resistance due to vasoconstriction, and there was increased diastolic blood pressure. But on these sites, there is decreased peripheral resistance due to vasodilation of the vessel, and there is decrease in diastolic blood pressure. That we commonly see in case of epinephrine, which act both on alpha and beta. So in such cases, in case of epinephrine, we rarely see any change in diastolic blood pressure. We only see usually increase in systolic blood pressure in case of epinephrine. As far as the vessel is concerned, in case of ciliary epithelium, so there is increased aqueous humor synthesis, so there is increased intraocular pressure in case of beta 2 activity. And the beta 3, they are also stimulating in nature, especially present at the level of adipose tissue. So it may lead to produce lipolysis and ultimately there is increased free fatty acid. In case of prolonged sympathetic stimulation in those patients due to increased free fatty acid, we observe that is why atherosclerotic change. These beta 3 receptors are also responsible for the release of nitric oxide. So nitric oxide itself is a vasodilator. So there is vasodilation. So nobivolol acts through increased this NO release nitric oxide by acting at the level of beta 3. So these were the discussion as far as the concept building of the activity of the sympathetic nervous system is concerned. Now we will start the proper discussion on the sympathomatic. Thank you very much.